Good evening. Welcome to the fourth webinar in the PSC Partners 2020 Annual Conference Webinar Series, The Basics of Primary Sclerosing Cholangitis, PSC. Thank you so much for joining us. My name is Mary Vyas. I'm the president of PSC Partners Seeking a Cure Canada, a Canadian registered charity and affiliate of PSC Partners Seeking a Cure. I'm coming to you this evening from Toronto, Ontario. Prior to the emergence of COVID-19, we had been looking forward to the 16th annual PSC Partners Patient Conference, originally scheduled for mid-April in Denver, Colorado. The annual conference is a highlight of my year and also for many in the PSC community, an opportunity to be together, to build community, and to support each other in person. The conference for many is a very important part of our toolkit of coping with PSC. The basics of PSC session is always offered, and for those that are newly diagnosed and for their caregivers and family, having an opportunity to review the basics of PSC and to ask questions of PSC specialists is so important. This session is always very well attended. And so it is with great pleasure that we bring you this virtual offering of this important conference session. Before we get started, I'm going to go over some logistics for this webinar. This Zoom meeting is set up as a webinar, meaning that aside from the panelists, the moderators, everybody is in listening mode and cannot be seen or heard. After the speaker presentations, there will be about 30 minutes for questions. Please use the Q&A box to submit your questions. At the bottom of your screen, you should see the Q&A icon. Depending on how your Zoom is configured, you may need to move your cursor to hover over the bottom of the screen to see the Q&A icon. When a question is submitted, only you, the panelists, the hosts, and the question moderators, Rachel Gomel and Joanne Hatchett, will see the questions. The speakers will try to respond to as many questions as possible, and the moderators may combine similar questions into one. When you submit a question, please put the name to whom you are addressing the question at the beginning of the question. Please keep your questions general. Speakers cannot respond to specific questions about an individual situation. And as always, please consult your healthcare provider for specific advice. All right, let's get started with a poll. Can we please launch the first poll? Okay, the question is, how did you hear about this webinar? Check all that apply. And the options are PSC Partners website, Facebook, Twitter, Instagram, PSC Partners mailing list, or word of mouth. Okay, so the results are over 50% heard about it from the PSC Partners mailing list. The next two are the PSC Partners website and Facebook, with a few people, Twitter, Instagram, and word of mouth. Thank you so much for participating. Thank you again for joining us. And now to introduce the agenda and our moderator to kick off the webinar, CEO and founder of PSC Partners Seeking a Cure, Ricky Safer. Take it away, Ricky.
All right, thank you, Mary. So I too would like to welcome all our attendees to tonight's webinar on the basics of PSC. This is the fourth in our webinar series to take the place of our April in-person conference that we sadly had to cancel due to the pandemic. Our expert speakers tonight from University of Colorado Health will cover basic PSC information, tests that PSC patients undergo and how to interpret the results, as well as symptom management. During the Q&A session at the end, the speakers will try to answer as many of your questions as possible. Our next webinar in this series will be Updates in Pediatric PSC, which will take place on Wednesday, August 12th. In addition to our educational webinar sessions, we are continuing to hold our informal Zoom rooms for the various peer groups in our community. Upcoming sessions will be spouses and other caregivers on July 28th and PSCers in their 20s and 30s on August 4th. I'd like to thank tonight's speakers, our conference co-hosts, University of Colorado Health and Children's Hospital Colorado, as well as our other corporate sponsors, Gilead, Mirum, Intercept, Alvarado, and Shire, for their support of our virtual conference webinars. Before we start tonight's program, I want to give a few reminders about upcoming programs where we will be relying on patient and caregiver participation. We want to make sure that you save the date, October 23rd, on your calendar to join us for Making Our Voices Heard, Patient-Focused Drug Development Forum. This is a one-time meeting approved by the FDA, and it's our big opportunity to shout out the PSC patient voice. It's our chance to tell our patients' stories, explain our symptoms and their impact on our lives, and also to identify our priorities for future treatments. We need our patients and caregivers to participate in this virtual forum to show the power of our community. This truly could become a game changer for PSC drug development in the future. We've created an important survey whose results will become the foundation for this meeting. I know that many of us, myself included, are suffering from survey fatigue these days, but we hope that every PSCer or parent of a PSCer will please take 30 minutes to fill this out. The greater the number of people complete it, the more valuable our community data will be for researchers, drug developers, and the FDA. We are planning to launch this survey later this week, and can we dare dream of having 1,000 responses? We are counting on you. A special announcement today is the launch of our updated PSC Partners Patient Registry, which is filled with new resources and features. We urge you to complete or update the registry clinical survey data and explore the new interactive features of our registry. You will see invitations soon to complete both surveys on our website, on social media, and through our newsletters. We are counting on you again to take part in our search for new treatments and a cure. Before we start our program tonight, I have a couple of polling questions for our participants. Could you please launch the first polling question? All right, the first question is, who are you? We'd like to know who's participating tonight. So I am a PSCer, spouse of a PSCer, parent of a PSCer, or other caregiver. Please choose one. Thank you. All right, the answers are in. So it looks like we have 54% PSCers, and of the caregivers, let's see, 25% are parents, and then we have 15% other, and 4% that are spouses. All right, we have one more polling question for you. All right, how long ago were you or your loved one diagnosed with PSC? So the choices are less than 3 months ago, 3 to 12 months ago, 1 to 3 years ago, or longer than 3 years ago. Please choose one. All right, looks like, let's see, 61% were longer than 3 years ago, 22% 1 to 3 years ago, 15% 3 to 12 months ago, and 3% less than 3 months ago. Thank you. All right, now I'd like to introduce our moderator, Dr. J.P. Norvell. Dr. Norvell is Assistant Professor of Medicine, Program Director for the Transplant Hepatology Fellowship Program, and Medical Director of the Inpatient Transplant Unit at the University of Colorado. I'll turn it over to you now, Dr. Norvell. Thank you.
Thank you. First of all, thanks so much to PSC Partners for organizing this webinar and also allowing me to participate. I find that patients with PSC and their caregivers ask a lot of great questions and also ask a lot of questions. And in part because there are so many topics to discuss, and it becomes quite overwhelming trying to navigate the process from diagnosis to management of PSC. Additionally, I think there's a lot of misinformation on the internet, and so I think it becomes even more important to allow patients and their caregivers to ask their questions right to the experts. I do think that this is a great opportunity to have their questions answered by 3 experts in particular, all here at University of Colorado. Without further ado, I'll briefly introduce them, talk about the agenda. Our first speaker will be Dr. Lisa Forman. The second will be Dr. Michael Kriss, and last will be Dr. Jay Burton. And each speaker is going to speak for about 20 minutes each, and I have to hold their feet to the fire and keep them to that. Then after all 3 presentations, we'll have about 25-30 minutes of your questions and answers, both from questions that have previously been asked, as well as questions that you ask live during this webinar. As you already heard, we ask that you please keep your questions general to try to help everybody, rather than asking very specific questions about your own care. So let me introduce first speaker tonight is Dr. Lisa Forman. She is nationally renowned in PSC, and I know that in part because I have read her textbook titled PSC. She has also been the program director here for our GI and liver training fellowship. So she's been responsible for our trainees over the past 15 years. Additionally, she serves as our principal investigator for our PSC clinical trials, which some of you may be participants in that. So without further ado, she is going to be discussing PSC 101. Dr. Forman?
Thank you. Great, thank you. So I want to thank Ricky for inviting me to give this talk. I have been involved in PSC Partners, I feel almost from its inception, and I think it's really a great resource that the world has really for all things PSC, and it certainly is a very empowering group to be a part of. So today I'm just going to be giving kind of a general overview about primary sclerosing cholangitis. So next slide, please. So the liver has many functions. It makes sugar, it detoxifies, it makes clotting factors and protein, and it makes bilirubin, which you need to digest fatty food. Bile ducts are a series of tubes in the liver that move the bilirubin to the gallbladder and then to the small intestine. And you have bile ducts that are both inside and outside of the liver. Next, please. Primary sclerosing cholangitis is a condition where you have inflammation and destruction of the intrahepatic and extrahepatic bile ducts, leading to cholangitis. And this process leads to segmental scarring and then stricturing, hence the sclerosing. And you can see from the picture on the right, actually the lower most picture, that instead of the tubes being nice and straight, you have areas of stricturing or narrowing and then dilation, stricturing or narrowing, giving the characteristic appearance of beads on a string or pearls on a necklace. Next. The pathogenesis of PSC is still not well elucidated. We think that there are many factors that are involved, such as exotoxins that comes with infection, endotoxins, auto and alloimmunity that lead to the initial insult of the biliary epithelial cells. In some people, this initial insult leads to an inflammatory response. In many, it's resolved, but in some, you have persistence of this inflammatory response leading to now chronic inflammation of the bile ducts. And once you have chronic inflammation, this can lead to scar tissue, turning yellow, and in some cases, malignant transformation. Next slide, please. It's actually a rare disease, and often at these meetings that I've been to, patients come up and tell me that it's the first time that they've met another person with this disease. So the incidence is actually only 0.5 to 1.3 per 100,000. There's a predominance of males over females. People with PSC tend to be young to middle aged with an average age of 40. And there's a strong association with inflammatory bowel disease, especially ulcerative colitis. If you look at all patients that have PSC, up to 80% will have ulcerative colitis. However, if you look at it the other way, if you look at all patients with ulcerative colitis, only about 5% will go on to develop PSC, and even less of those that have Crohn's disease. Next, please. Typical symptoms are itching and fatigue. Some people may present with yellow eyes or jaundice, weight loss, malaise, abdominal pain, and fever. And many patients with PSC actually have no symptoms at all. Next. In terms of the labs, Dr. Kriss will be going over this in more detail, but many patients will present with an elevated alkaline phosphatase. That's the enzymes that the bile ducts make. The ALT and AST are often 2 to 3 times higher than normal, and most people will have a normal bilirubin at diagnosis. And these liver function tests over the course of the disease may fluctuate. They may be elevated, they may be normal. When someone is first noted to have abnormal liver function tests, it's important that your doctor excludes other diseases and then needs to exclude secondary causes of sclerosing cholangitis. Next, please. Over 95% of patients with PSC will actually have the presence of autoantibodies, and the clinical significance of these antibodies are really unclear. It may predict patients who in the future may develop another autoimmune condition such as autoimmune hepatitis, but not necessarily. So what do we mean by autoantibodies? Anti-nuclear antibody, anti-smooth muscle antibody, p-ANCA, and IgG4. Next, please. So how does one make the diagnosis of PSC? Next. So often when someone presents with elevated alk phos, the first test that a doctor will check is an ultrasound. And actually the vast majority of the time, ultrasounds in patients with PSC are completely normal. Occasionally you may see a thickened bile duct, and that's what the yellow arrow is pointing to. Next. Another non-invasive test to check is called an MRCP, or magnetic resonance cholangiopancreatography. This is an MRI that is protocoled specifically to look at the bile ducts. And in PSC with MRCP, you often will see the thickening and the dilation of bile ducts. Next, please. The gold standard, of course, is an ERCP, or an endoscopic retrograde cholangiopancreatography. This is an endoscopy where the GI physician will go in and do a scope, enter the stomach, the small intestine, and then will insert contrast into the liver, into the bile ducts. And if you see the characteristic appearance of strictures in dilation, as illustrated in the picture below, this is diagnostic of PSC. Next, please. Well, what about a liver biopsy? Well, we actually do not use liver biopsies to diagnose PSC. The exact role of liver biopsy is really undefined. Usually I use a liver biopsy if I'm concerned that there might be another condition on top of PSC. The reason we don't use a liver biopsy to diagnose PSC is often the biopsy is completely normal. Most of the inflammation and strictures in patients with PSC are in the large bile ducts. And when we do a liver biopsy, we're at kind of the periphery of the liver where the small bile ducts are. And so we often will not see any abnormalities at all. If you do happen to get a biopsy of the large bile duct, you will see the characteristic of what we call onion skinning around the bile ducts, which basically represents the layers of scar tissue. And I think you can see that illustrated in the blue on the bottom right picture, where you see concentric circles. And again, that's the onion skinning or the layers of scar tissue. If someone is wondering how much scar tissue they have in general in the entire liver, you can get a FibroScan, which is a non-invasive test. And I believe Dr. Kriss will be talking about that as well. Next, please. Now, PSC has come to really represent many, many different diseases. It's really not the one disease entity that we thought about it. Most of the time it does affect the large ducts, but there are some patients where the large ducts are actually unaffected. The ERCPs are actually normal, but the biopsy will be abnormal. This is called small duct disease. Pediatric PSC tends to be very different than adult PSC. When patients present with PSC, they often have another autoimmune disease on top of it, such as autoimmune hepatitis. African American patients with PSC tend to have a lower rate of inflammatory bowel disease and a less predominance of male. Patients that don't have IBD tend to be older, equal prevalence between males and females, and they may have a better prognosis. There's secondary sclerosing cholangitis, which can occur with, for example, HIV or lack of blood flow or ischemia. IgG4 PSC, that's one of those autoantibody markers that I mentioned, can be associated with an autoimmune pancreatitis and diabetes. It tends to be in older males, and it can be more aggressive. We'll briefly talk about PSC after transplant, and PSC can present with an overlap with autoimmune hepatitis. Next, please. What's the natural history of PSC? Well, this is unfortunately a progressive disease. Spontaneous resolution does not occur. The initial data for PSC was actually grim, and we thought that it was inevitable, that it was progressive, and people will absolutely end up needing a liver transplant. Although it is true that many people will end up needing a liver transplant, most of that data comes from academic liver transplant centers. If you actually look at the graph on the right and you look at the survival rate in looking at a full population as opposed to just the liver transplantation cohort, that's represented by the darker black line. You see that the prognosis is much better than if you just looked at the liver transplant center cohort. It's important to know that patients with ulcerative colitis that have had their colons taken out, it does not impact the history of primary sclerosing cholangitis. And there is some thought and some data that patients that are completely asymptomatic may actually have better survival. Next, please. A lot of patients come to me and they just want to know, well, how bad do I know my PSC is? What can I look at? Well, I just have up here 2 scores that I think are very helpful. They both have apps that you can load on your computer. The first one is the Mayo PSC risk score. And the second one is a similar score, but the data is derived from the European population. And basically it will ask you for your age, some of your lab values, what your platelet count is, for example. And then it will give you information on your 1, 2, 3, 4, 5-year survival rate or your transplant-free survival rate. So I think that is potentially a good resource for you guys to look. And again, it's just loaded up on your phone. So every time you get labs, you can plug it in if you're interested. Next, please. What are some of the complications that can occur now in patients with PSC? I'd say the majority of patients will develop infection or cholangitis. Basically, when you have these strictures in the liver, by definition with PSC, you do have strictures of the bile ducts. The normal bacteria that are in the bile ducts don't flow freely into the intestine, and it can back up and you can develop infection or cholangitis. Because of strictures, people with PSC can develop stones of their bile ducts, and stones in the gallbladder are also quite common. Patients with PSC, some of them won't even present with strictures or infection, but actually cirrhosis where the entire liver is scarred. So instead of having complications such as an infection, you start seeing complications of what we call portal hypertension or elevated pressures related to that scar tissue, such as liver failure, varices, ascites. Next, please. Malignancy overall is increased in patients with PSC, and I think that this is one of the scariest things to discuss with patients, and there's just so much uncertainty. But cholangiocarcinoma or bile duct cancer is greatly increased when you have PSC. It can occur at any time in diagnosis, and people with PSC carry about a 10 to 20% lifetime risk of bile duct cancer, or about 0.5 to 1% per year. Patients with PSC and ulcerative colitis also have a higher risk of developing colon cancer as well as abnormal cells in the colon. There's a higher risk of pancreatic cancer, liver cancer, as well as gallbladder cancer. So we are much more prone, if we do an ultrasound and see a polyp in the gallbladder, to send you for a cholecystectomy, as opposed to waiting to see if that polyp grows. Next, please. Other complications include osteoporosis and osteopenia, itching, elevated cholesterol levels. Once a person becomes sicker with PSC and their bilirubin starts rising, we'll start to see deficiencies in your fat-soluble vitamins. Malabsorption can occur, and fatigue can occur. Next, please. In terms of therapy, well, PSC is considered an atypical autoimmune disease. It's considered atypical because it's much more common in men as opposed to women. Most women develop autoimmune diseases, and it's atypical because it tends to respond poorly to typical immunosuppressive therapies. And at this point, there is no proven effective medical treatment. So far, there have been no therapies that have been shown to prolong survival or change the natural history. And the therapy of inflammatory bowel disease has little effect on PSC course and vice versa. Next, please. So again, to reiterate, as of now, there's no proven pharmacotherapy for the treatment of PSC that is able to reduce disease progression or improve mortality. Next. So what about ursodiol? So ursodiol is a bile acid. It actually initially was found when they were killing bears in Alaska and looked at their gallbladders and realized that their gallbladders had a more favorable content of bile acids than humans do. Urso is the Latin name for bear, and so that's how you have the constellations, Ursula Minor, Ursula Major. Ursodiol, many patients with PSC are put on Urso, and the data is kind of very variable. If people are put on low dose Ursodiol, the alk phos tends to get better, but it doesn't change the natural history. If you go on high dose Urso, that clearly has been shown to be detrimental to patients with PSC. And medium dose Urso, which is the 15 to 20 mg per kg, we're really not sure about, and there are studies looking at that right now. But if you look at our two major liver societies, one from the United States and one from Europe, ASLD says still in adult patients with PSC, they recommend against the use of Urso. And EASL from Europe says the limited database does not yet allow a specific recommendation for its general use. Next, please. It is, however, a very exciting time for PSC, and there's lots and lots of research being done now looking at future potential therapies. I'm just going to highlight a couple of them. Nor-Urso, if you've done any reading in the PSC literature or on the web, this is a homologue of Urso. It is not available in the United States, but in Europe, there's some data that suggests it might be beneficial. There's no head-to-head trial, though, with any other medication as far as I know. In terms of vancomycin, most of the data with vancomycin comes from the pediatric population in patients that have inflammatory bowel disease. There really have not been any trials looking at vanco when you don't have IBD, and its benefit in that population is unknown. Mayo at this point is doing a big vanco trial. Obeticholic acid is a promising drug. It's a drug that's actually approved for a different type of biliary disease. The study was on hold for a while, but I've heard that they're going to have that up and running again. In addition, there's a bunch of other medications such as berberine that might be short-tracked actually for FDA approval. Bezafibrate is a lipid-lowering medication that is only available in Europe, and it has very favorable results from those studies. Not only does it make the alk phos better, it tends to help fatigue and itching. And we don't have bezafibrate other than clinical trials, which are starting right now, but we do have fenofibrate, sulfasalazine, and even fecal transplantation. Next, please. So because there's no really great medication to help PSC, most therapies are directed at the complications rather than the underlying cause. Next, please. So if you're itchy, take antipyretic agents. Dr. Burton will be talking about that. If a person has infection, we use antibiotics, and then we often will want to see why they have an infection and want to interrogate the biliary tree more to see if there's one stricture that's more strictured that potentially can be dilated and stone swept. So in that case, using an ERCP, the more invasive test, would be the treatment of choice, because once you have a scope within the bile ducts, you actually can dilate those bile ducts, you can put a stent in, you can remove stones, you can biopsy, you can take a look at the cells under the microscope, so it's very helpful. PTC can also be used if the doctors cannot get access to your bile ducts internally with ERCP. And I have a picture of that next, please. So PTC stands for percutaneous transhepatic cholangiography, where the radiologists are able to find a dilated duct and then go from the outside of the skin within to the liver, put a stent, and then you are left with a tube that is coming out of your skin that sometimes is attached to a bag. Next, please. Stenting, I just wanted to show you a picture of what that means. A stent is basically just a plastic tube that's inserted into the bile duct, and what it basically is doing is it's manually dilating your strictured bile ducts. And so that stent is kept in for a little bit, and then you have another ERCP, and they keep doing that, putting more stents in until that stricture disappears. Next, please. Moving on to bile duct cancer, just a couple of slides on this. Picture on the left is just what it looks like on the microscope. On the right is a picture of an ERCP, and you can see there's a big filling defect where the large arrow is. Next, please. Risk factors for developing cholangiocarcinoma are patients that have elevated bilirubin, that have had a variceal bleed, that have had their colon taken out, that have ulcerative colitis with abnormal cells. And there's definitely some genetic polymorphisms that have been recently associated with bile duct cancers. Next, please. Unlike colon cancer, where you can do a colonoscopy and take biopsies and see if there's any abnormal cells, with bile duct cancer, screening tends to be very challenging and often is ineffective. What we do at the University of Colorado is we get annual CA19-9s, Dr. Kriss will talk about that, as well as annual MRCPs. If a person has been diagnosed with bile duct cancer, liver transplantation is actually possible, and most transplant centers follow the specific protocol that was developed by the Mayo Clinic. Next, please. This is just a brief graph showing that if you have an elevated CA19-9 level, in this case greater than 129, plus some abnormal genetic cells with brushing on ERCP, you have a higher rate of developing cancer over the next 5 years. So that line is the one at the top, and the line at the bottom is having no abnormal cells and normal CA19-9. Next, please.
Sorry, Dr. Forman, if you don't mind trying to wrap up. We think we're getting tight on time.
Okay, so bone disease is extremely common. We recommend getting DEXA scans at diagnosis. Next, please. We screen for fat-soluble deficiencies. We do vaccinations, and we do annual colonoscopies. Next, please. Couple slides on liver transplantation, and then I'll end. Next slide. About half our patients at university will get transplanted within 10 years after diagnosis, but a half are not transplanted. Next, please. The big question is, when will I need it? And patients usually do quite well, but then when you start developing more and more infections, start turning yellow, and the yellow is persisting, then it's really time to start thinking about liver transplant. Next. Liver transplantation can occur from a deceased donor, or we really encourage people with PSC to think about live donation. Next, please. People do really well with transplant after their transplant, with a 90% 1-year survival, 84% 2 years. I will mention, though, that 30% will have recurrent PSC, but even those that have recurrent PSC do well. People that tend to develop recurrent PSC have active inflammatory bowel disease with an intact colon, male, and history of cholangio. Next slide. Inflammatory bowel disease can occur and worsen after transplant, but it can get better. Next. So in conclusion, PSC is a chronic immune-mediated disease with unclear etiology. Medical therapy is limited. It's currently targeted at complications. People can develop portal hypertension and liver failure over 15 years from diagnosis. Next. I think it's important to be referred early to a transplant center. When you have advanced disease, liver transplantation is really the only treatment, but they have excellent outcomes, and new therapies are desperately needed. And there are many in the pipeline, so I really encourage all of you to think about enrolling in a clinical trial. As mentioned, Mayo is doing a Vanco trial, and I have listed here the email of my study coordinator if anyone is interested to see if they might be a candidate for a study here. And then it's really, really important for everyone to have a good support system. Thank you.
Thank you, Dr. Forman. That was great. I'd like to move on to our next speaker, Dr. Michael Kriss. Dr. Kriss is a rising star in the field of hepatology. He is also known nationally. He was recently elected to a position in the American Society of Transplantation and has a background in translational research. The talk that he is going to be presenting now is titled "How to Interpret Your Tests Like Your Hepatologist's: Keys to Being Fully Informed Participant in Your PSC Care." Dr. Kriss.
Great, thank you, JP. So today I'm going to be talking about how you can interpret your tests like your hepatologist, and really the goal is to become a fully informed participant in your PSC care. Next slide, please. I have no disclosures. Next slide, please. So today I really have three main objectives. The first is to review how to interpret your liver function test and your CA19-9, which Dr. Forman discussed, and identify how changes in those may reflect changes in your PSC. Next, we'll review imaging and non-invasive diagnostic tests used to assess your PSC and ultimately inform your clinical decision-making. And then we'll conclude by understanding how we use ERCP diagnostically and understand how that informs your care. Next slide, please. Now, this is Albert Einstein, who is responsible for the theory of relativity. And it's important to keep in mind that in PSC, normal and abnormal is all relative. Okay, so most of you with PSC will have baseline elevations in your labs, and really it's how much of a change from that baseline that dictates whether or not they're truly abnormal for you. Next slide, please. Now, when it comes to liver tests, as mentioned by Dr. Forman, we think about first liver transaminases. These are your aspartate transaminase, or AST, and alanine transaminase, or ALT. They've actually scientifically defined what is normal for ALT, and that's less than 33 international units per ml. That's a uniform unit used across labs. And these transaminases leak into the blood when liver cells or hepatocytes die and ultimately lyse. So what do elevations mean? Well, as mentioned by Dr. Forman, having elevations about 2 to 5 times the upper limit of normal is expected in PSC. When elevations become higher than that, 5 to 15 times the upper limit of normal, most often I think about, is there something going on with your PSC? Is there progression of disease? Is there superimposed cholangitis? And when labs get even higher than that, so greater than 15 times the upper limit of normal, that's when we really worry about secondary liver diseases that are not PSC, such as autoimmune hepatitis. Next slide, please. Now, alkaline phosphatase, as mentioned, is the classic liver enzyme that's elevated in PSC. A normal value is less than 126. And this is an enzyme that's secreted primarily by bile duct cells or cholangiocytes. Now, importantly, while alkaline phosphatase is made by the liver, it's also made by the bone, the intestine, and the placenta. And so there's a test you can do called an isoenzyme test that will allow you to distinguish from which of those organs the alkaline phosphatase comes from. Now, another tool that we use independent of that test is if you check a gamma-glutamyl transferase, or a GGT, and that's elevated, that is consistent with the alkaline phosphatase coming from liver origin. Now, when it comes to elevations, what do they mean? Well, most of you will have some baseline elevation in your alkaline phosphatase, and then changes from that baseline would suggest biliary obstruction, superimposed infection or cholangitis, or potentially both. Next slide, please. Now, when it comes to bilirubin, this is a little bit more complex because there's two types of bilirubin. There's unconjugated or indirect bilirubin and conjugated or direct bilirubin. A normal total bilirubin, which is the two of those combined, is less than 1.2 milligrams per deciliter, so a different unit than the other enzymes. And it is important to have a basic understanding of how this bilirubin is normally produced and metabolized in your body. Bilirubin is actually a normal breakdown product of heme, which is a protein in blood. And so in that form, it's unconjugated and circulating in your peripheral blood. When it then comes to the liver is responsible for conjugating the bilirubin. And this is important because it makes it so that bilirubin is soluble in water and can then leave your body. And it leaves your body by then being secreted by those liver cells into your bile, and then ultimately going into your intestine and being excreted from your body in your stool. Next slide, please. So when we look at these unconjugated and conjugated bilirubins, it helps us understand what could be driving elevations. So for unconjugated, if you have increased breakdown of red blood cells, which is called hemolysis, you will see that number go up. Sometimes there's also problems with the liver actually conjugating the bilirubin. Now that could be from genetic issues, such as a benign condition called Gilbert's, or cirrhosis, which would obviously then be acquired. Conjugated or direct hyperbilirubinemia occurs most commonly when there's a blockage of the bile duct, so the bile itself that contains that conjugated bilirubin can't leave the liver. Or cholestasis, which is a term that describes impaired cellular secretion of bilirubin. And then if there's significant injury to the liver cells or hepatocellular injury, that can also increase your bilirubin. Next slide, please. Now, in addition to your liver enzymes, we look at what are called synthetic markers of your liver, or how is your liver functioning. And the two most valuable tools we have are your prothrombin time and your albumin. Now, prothrombin time measures in a test tube the time it takes for your blood to form clot. And that is measured in seconds, but then can be normalized into what's called an international normalized ratio, and that a normal INR is 1. So if you have an elevation in your INR or a prolongation of that PT time, it reflects impaired clotting. And listed there are the 5 factors that are involved in clotting for this specific test. Now, obviously, if the liver is not functioning well, the liver is responsible for making clotting factors. And so in those instances, it will prolong your PT and increase your INR. Another scenario that can occur in PSC is factors 7 and 10, which include an asterisk there, require bilirubin to enter the intestine to help you absorb what is called a fat-soluble vitamin, which is what vitamin K is. So if you are not getting bilirubin into your gut from a bile duct blockage, you can become vitamin K deficient, and that also can increase your INR even if your liver is functioning normally. Now, your albumin is a protein that's also made by the liver. A normal level is greater than 3.5 grams per deciliter. And again, low levels can reflect impaired liver function. However, this becomes a little bit more complicated because albumin is what we call a reverse acute phase reactant. So in your body, when you have inflammation, your albumin levels will go down. So for instance, if you had cholangitis, your albumin would be low, but that doesn't necessarily mean you have impaired hepatic function. And then in those of you who may have concurrent inflammatory bowel disease, malnutrition or malabsorption can contribute to protein losing issues that create a low albumin state. Next slide, please. Now, I want to spend a few minutes here talking about CA19-9, which stands for cancer antigen 19-9. This was mentioned by Dr. Forman, but it's a modified Lewis A blood antigen. And a normal level is less than, actually, this was a typo, it should be 129, but roughly the same. And this marker can be elevated in gastrointestinal cancers, specifically bile duct cancers or cholangiocarcinoma and pancreatic cancer. However, it can also be elevated if you don't have cancer but have an obstruction of your bile duct. And therein you can see the problem in having to discern the two in patients with PSC. Now, an important thing to keep in mind is that 7% of our population does not have the Lewis A blood antigen. And so there's 7% of our population who, if they had a bile duct cancer, for instance, would not have an elevation in their CA19-9, because they do not have that antigen. So how do we use it? So really this is a screening tool that we use in conjunction with an MRCP, which Dr. Forman mentioned. And really it's not diagnostic, it just determines if you need additional testing specifically to evaluate for cholangiocarcinoma. Next, please. So what does an elevation mean? Well, there has been a study done on a series of patients from Mayo Clinic, and this is actually for the 2000s, so a 10-year period. And they had 73 patients who they followed for an average of almost 3 years after having had an elevated CA19-9. And it's important to note that over a third of those patients did not develop cholangiocarcinoma. And you can see that in those who did not develop it, their average CA19-9 was still twice the upper limit of normal. Now, it was not as significantly elevated as the group who developed cholangiocarcinoma. And in fact, those who had a level over 2,000, all of those patients had cholangiocarcinoma. Now, in this study, they tried to develop a threshold above which the CA19-9 would be very helpful diagnostically. And as you can see, their rates of true positive were 67% and true negative 74%, which may sound okay, but when you're talking about a bile duct cancer, that just doesn't really cut it and doesn't provide any degree of certainty. So ultimately, you really need to interpret an elevated CA19-9 in the context of every individual patient's symptoms and other diagnostic tests like an MRCP and ERCP. Next slide, please. So moving on to MRCP, this stands for magnetic resonance cholangiopancreatography. And there's really three uses in PSC that I use this for. The first is to diagnose PSC. The second is to evaluate if there's any change in your clinical status to assess for disease progression. Do you have a new stricture? Do you have concern for a cholangiocarcinoma? And then as Dr. Forman mentioned, both our Liver Society guidelines and the most recent PSC guidelines actually come from the American College of Gastroenterology from 2015, but those also support the use of MRI with a CA19-9 to screen for cholangiocarcinoma every 6 to 12 months. And as Dr. Forman mentioned, we do that annually in our group. And then one important thing to keep in mind is that with an MRCP, the pictures of the bile ducts that we get that are so crisp and diagnostic actually use your own bile as a contrast agent. And so while you should have gadolinium, which is the MRI contrast agent with that test, if for some reason you had a contraindication to that, that is still a tool that we can use that can be diagnostic. Next slide, please. Now here on the left is an MRCP and on the right an ERCP, and these are from the same patient, so the same bile duct system. And what you can see on the MRCP is that there is an extensive network of bile ducts, which are basically those lines coming off of the red circle. And those lines extend to the edge of the liver, which is not normal. You can also see breaks in the bile ducts with alternating dilation and narrowing, which we call beading. And then that red circle is where the bile ducts make a Y shape called the bifurcation, and there's a stricture there. Now this patient had the MRCP, then went to ERCP to both treat that stricture, meaning dilate it and stent it, but also take samples, which we'll discuss momentarily, to exclude cholangiocarcinoma. So really you should think of MRCP as highly accurate to diagnose PSC, to evaluate for new dominant strictures, and to evaluate even for cholangiocarcinoma. And then ERCP is really therapeutic to place stents, for instance, and helpful for tissue diagnostic roles if there's a concern for cholangiocarcinoma. Next slide, please. Now, when it comes to ERCP, Dr. Forman had mentioned how this procedure works. I'm going to tell you how we sample this tissue. So the first way we can sample is with brushing. So this is essentially a pipe cleaner that goes in your bile duct, and they rub it up and down to slough off cells. And it looks like the picture on the bottom, where there's a collection of just blue dots, which are individual cells that are looked at under a microscope. What we use at our center very often is what's called cholangioscopy. So that's pictured in the middle column on the top. That's actually a picture from inside the bile duct. And normally that should be very smooth and rounded. And you can see this bile duct has very abnormal contours to it. And so in this way, we can actually not only look at abnormalities, but then take a very small biopsy forceps, which is pictured in the top right, to take directed pieces to increase the diagnostic yield. And you can see in the picture on the bottom, what you see under a microscope is very different, because instead of a collection of amorphous cells, you actually see the architecture of the bile duct lining. And then the third tool we use is FISH. And so again, this uses in situ, or what's called fluorescence in situ hybridization, to label chromosomes. Now, every cell in your body should have 23 pairs of chromosomes. And if they have fewer pairs or more than a pair of any chromosome, then that's an abnormal cell. And so the FISH, you take this same pipe cleaner, scrape off cells, and then you stain them with these probes and look at them under a microscope. And what are pictured here are individual cells. And on the left is a normal cell. It has 2 of each color of chromosome. On the right is a cell that has 4 red chromosomes and 3 blue, And so that is a cell that has what we would call polysomy. Okay, and polysomy is the fish abnormality that we are most concerned about being associated with cholangiocarcinoma. Next slide, please. Now, when it comes to these three tests and we're thinking about diagnosing cholangiocarcinoma, they are all very specific, meaning if they are positive, then that means that that diagnosis is not 100% certain, but about as close to that as you could be. However, if it's negative, it's not highly sensitive, okay? So for instance, about only half of patients who have a cholangiocarcinoma will ultimately have positive, for instance, brushings. And so we use these tools in conjunction, again, with your other tests to help make these decisions. And there are times where we don't have a definitive diagnosis, but we have enough suspicion of cholangiocarcinoma that we proceed as if that's the case. Next slide, please. Now, FibroScan or transient elastography is a way that we can actually monitor disease progression. And this is disease progression, not progression of strictures, but progression of scarring within the liver from the chronic bile duct obstruction. And this is a test that uses a probe that's pictured here. And that black tip of the probe actually pushes on your liver, creates a tissue wave. And then on the right, that black line is that tissue wave. And you measure how long it takes to cover a fixed distance. And that tells me how stiff your liver is, which correlates to a fibrosis stage or scarring stage. And this is validated in PSC. And in my practice, I use this when I meet patients initially, and then it allows me to have a baseline to monitor them every usually 3 to 5 years so that I don't have to do something like a biopsy to see how much scarring is present. Next slide, please. Now, the MELD score is something you all may have heard of. The MELD score is something we use in liver transplantation to prioritize how sick an individual is and prioritize urgency for liver transplant. It incorporates your bilirubin and INR, which we've discussed, but also 2 markers of kidney function, your creatinine and sodium. And it's important to note that this is really used in patients who have cirrhosis and decompensated liver disease. And in that scenario, PSC patients are generally disadvantaged by the MELD, meaning your risk of dying from complications of your liver disease is higher than your MELD score would suggest. And it is also very important to keep in mind that there can be very large and dynamic ranges that can exist for a MELD in individuals. So for instance, the MELD goes from 6 to 40. Your MELD might be 6 because you have a normal INR and a normal bilirubin. And if you develop cholangitis and a bile duct obstruction and your bilirubin goes up to 10, your MELD may double. That doesn't mean that overnight you've doubled your risk of dying from liver disease. That just is a dynamic change from that complication. Now, if that change happened over a period of months when you had cirrhosis because your liver was getting sicker, then that's a totally different scenario. Next slide, please. So in conclusion, it's important to keep in mind that PSC is a chronic yet dynamic disease that requires monitoring over time. The tools we use are laboratory testing, and that really has to be interpreted in the appropriate clinical context. So what's happening to you, the patient? And MRCP is a very, very valuable diagnostic tool and is really the diagnostic tool of choice in PSC, with ERCP being reserved primarily for interventions and tissue sampling. And then transient elastography is a new tool that we have, and it's really important for us as hepatologists and you as our patients, because it allows us to assess for and monitor fibrosis progression without performing biopsies. With that, I'll conclude and turn it back over to Dr. Norvell.
Thanks so much, Dr. Kriss. That was great. Our third and final speaker here is Dr. James Burton. Dr. Burton serves as the medical director of our liver transplant program here at University of Colorado. He was promoted to full professor status today, so congratulations, Dr. Burton. He will be discussing a very important topic today that should hopefully answer a lot of questions that you may have, entitled Symptom Management in PSC. Dr. Burton.
Thank you, Dr. Norvell. Pleasure to be with you this evening. I'll talk about symptom management. Next slide. So just to outline, we'll talk about some of the things that may have already been discussed tonight, but I'll probably go into a little more detail of specific treatments for these things. We'll talk about cholangitis, pruritus or itching, which is a big problem with PSC, and we'll talk about specific therapies for that. We'll talk about fatigue and how it can impact people with PSC. And then we'll talk about some complications of cirrhosis, specifically ascites, hepatic encephalopathy, and sleep disorders. Next slide. So this slide summarizes some of the prevalence of symptoms in PSC. And I think the first thing to notice is that despite having this condition, one can have absolutely no symptoms of PSC. A lot of the symptoms that people might experience may also include pruritus, jaundice, of abdominal pain, fevers, and chills. And I notice right now that I outlined put the wrong little doohickey next to there, but those are all symptoms associated with cholangitis. Next slide. So cholangitis can be a complication of infection of bile ducts from obstruction of the bile ducts, as has been discussed. And a lot of those symptoms can occur with right upper quadrant pain. This pain isn't like chronic right upper quadrant pain, but can be more acute in nature. Associated nausea, vomiting, fevers, chills. You might expect cholangitis to develop worsening or new jaundice, worsening or new pruritus or itching. And in severe cases, it can cause sepsis or low blood pressure. Next slide. So the management of cholangitis, has been mentioned, is antibiotics. And these can be either given orally or intravenously. There are many oral antibiotics that work just as well, whether they're taken by mouth or given through an IV. And a lot of times you could start antibiotics as an outpatient before having to come in to the hospital. And then once someone has cholangitis, you should assess whether they have evidence of biliary obstruction. This can be done simply with an ultrasound, and if it shows dilated bile ducts, obviously you have some sort of obstruction. As was mentioned earlier, an ultrasound being normal does not rule out obstruction. Oftentimes an MRI is done, specifically an MRCP, to assess for biliary obstruction. If you have a patient who's known to have PSC, who's known to have recurrent cholangitis, I would argue that's kind of a waste of time, and you should just go ahead and go straight to endoscopic retrograde cholangiography or an ERC, where you actually go into the bile ducts and can remove stones, dilate strictures, and if necessary, sample those strictures for cancer. And as also was mentioned, sometimes if people have complications that are not amenable to ERCP, you can do percutaneous transhepatic biliary drains or PTC catheters that Dr. Forman talked about. Next slide. So pruritus is just a fancy medical word for severe itching. It's a common symptom of liver disease, often the result of poor bile flow. And poor bile flow is termed cholestasis. And there's many liver diseases that one would describe as cholestatic liver diseases. And these would include primary sclerosing cholangitis, as we've been talking about. It also would include primary biliary cholangitis, or PBC, any disease that causes bile duct obstruction, whether it be from a tumor or a gallstone. Sometimes other liver diseases like hepatitis C can cause it. And also a condition of cholestasis of pregnancy can cause severe itching as well. Next slide. So the first line of therapy when you have someone who has cholestatic pruritus is to relieve the biliary obstruction. And we've talked about doing ERC and PTCs to go into the bile ducts and look and see why there might be an obstruction and relieve that obstruction. Now, sometimes PSC can cause small bile duct obstruction, which is not amenable to any endoscopic therapy, unfortunately. Next slide. It's also important when you have itching or pruritus to ask yourself, is this related to the liver? And if someone has PSC and it's mild and they have normal liver tests and they were just diagnosed with it coincidentally from other imaging testing and they're having itching, you might want to think about other causes of itching. And a big cause of itching here in Colorado is certainly dry skin from our warm environment. So you might need to think about skin conditions. There are also kidney conditions, blood diseases, endocrine diseases like diabetes, infectious diseases, autoimmune diseases, neurological diseases, and unfortunately other psychogenic disorders that can cause itching. So not all itching in PSC is related to the liver. Next slide. Now, cholestatic pruritus will occur in about 20 or 30% of patients who have cholestatic liver disease. So not everyone is going to develop this. It often fluctuates in severity and generally is worse at bedtime. And it has the potential to drive you and your significant other crazy. Next slide. Now, there's some simple treatments for pruritus that you should always think about, whether or not it comes from the liver or not. One is to stay cool. You want to avoid hot showers. Hot showers will dilate the skin and cause things to get worse. You want to minimize dry skin. You want to use a good moisturizing soap. I'm not paid by Dove or Eucerin, but I'm just saying these are some good ones to try. You want to keep your skin moist. You want to get out of the shower and lather down with a good moisturizing cream. You want to you'll probably be more comfortable with looser fitting, lighter clothing, particularly bed coverings. Opioids are known to make itching worse, and actually there's some of the treatments for itching can be to block the effects of opioids. We'll talk about that later. You want to stay cool and collected and not be too stressed out. I've had patients who are very anxious, and when they get anxious, their itching gets worse as well. And you also want to avoid this physical intervention, this itchy scratch cycle where you itch, you scratch more, you itch more, and it just keeps going on and on. That cycle can be difficult to control and make things worse. And then there are a number of topical agents that can be tried to help. And I certainly think they're worth trying, though I must say in most people, I don't think they're highly effective. But if someone says they work, by all means do it. Next slide. Now, these are some of the medical treatments for cholestatic pruritus. The ones on the left, bile acid binders such as cholestyramine, rifampin, and opioid antagonists, I'll talk about in a bit more detail on next slides. The drugs on the right are also drugs that have been used in itching. Sertraline is an antidepressant that has some effects with pruritus. Doxepin can be given. It also has a side effect of making people sleepy, good to take at night. Phenobarbital is not something I use too commonly. It has a lot of drug interactions, but it has been shown to be effective. There's this nausea medicine, Burton, which is a medication used for chemotherapy nausea, which actually has some anti-itching properties, which I've used in some patients who've been really refractory to other drugs with good results. And then there's some non-medical treatments such as plasmapheresis, where you actually remove the plasma from your blood, and then replace it with fresh frozen plasma. This can be done. It's pretty invasive. There's also a system called MARS, Molecular Absorbent Recirculating System, which is kind of like the equivalent of liver dialysis, which has been used to help with itching. Again, quite invasive, and not every place has one of these instruments. UV light may be effective, and that has been tried. And I'm also hearing that there's a lot of effects of these new therapies for PSC that might actually help itching as well. Next slide. So bile acid binders are really the first line therapy for people with pruritus. These are non-absorbable resin binders that bind bile salts. And were used to treat elevated cholesterol, and they've also been used to treat diarrhea after cholecystectomy. The initial dose is 4 grams, which is what comes in a little packet, and it's usually taken 1 to 2 times a day, up to 3 times a day. I typically have my patients take it at night because that's usually when they have the most symptoms. It can have some side effects such as nausea and bloating, and particularly constipations, which can be problematic. Another important thing is it can bind other medications, and I've listed some common ones there. So it's important if you take it to take your medications 1 hour before, or it's 4 hours after you take the cholestyramine. Next slide. Another drug used to treat itching is rifampin. Now, rifampin is a drug used to treat tuberculosis. It doesn't have many other treatments. How it's used and why it works is not completely understood. It may compete with bile acids for uptake in the liver. And there is thought to be that bile acids play a role, though bile acids are not depositing in your skin and are not the reason you itch. It also may induce some enzymes in the liver that promote the reduction of toxic bile acids, which may make things worse. Usually I start off with about 300 milligrams in divided doses twice a day. You can go up to 600 milligrams in divided doses. It is worth noting that it does have side effects, and one of those side effects is acute hepatitis. So it is something that needs to be used with caution, especially with advanced liver disease and monitoring liver enzymes. And one thing you should always know, if you do take this, it will turn your urine and your tears bright orange. And so it can be quite startling. And it has several drug-drug interactions, so it is something that you need to review your entire med list to make sure there's not going to be any other drug-drug interactions that inhibit other drugs or make other drugs not being cleared from your body. Next slide. Now, opioid antagonists do the exact opposite of what an opioid like morphine or fentanyl or heroin would do. And these drugs block the opioid receptors in the brain. And these drugs are also used to treat people with drug abuse as well as alcohol abuse. And these drugs have actually been shown, if you block the opioid receptor, because there are things floating around in your body that bind to these opioid receptors that can cause itching, that if you block these receptors, you can actually improve itching. Now, these are problematic because if you do have opioid use, you can't take them because they won't work anymore. So if you have a history of chronic pain, you're going to have a really, really bad pain. And if you're having any planned procedures where they're going to use an opioid to help with sedation, you need to come off the medication at least a week ahead of time. So while they may be effective, I don't think they're a first-line agent for all these reasons. Next slide. Current American Association for the Study of Liver Disease guidelines for treating pruritus is to start with bile acid sequestrants like cholestyramine, with second-line agents be to add rifampin, naltrexone, and sertraline. I actually probably start sertraline a bit earlier because I don't think it has as many side effects, and I usually don't start as high of a dose as currently recommended by the ASLD. I would say it is worth noting that anyone who has severe incapacitating or refractory pruritus, that would be an indication to consider liver transplantation. Next slide. Now, fatigue is a very common symptom in general, and it is a common symptom in people with liver disease, particularly patients with PSC, as well as primary biliary cholangitis. I think it's important when you have the symptom of fatigue, since it is so common, that you do have an assessment for other conditions that can cause fatigue, such as anemia, hypothyroidism, depression, and sleep disorders, which are also common in liver disease, and I'll talk about more. There has been some studies looking at ursodiol with mixed results, and I don't think it hurts, but I don't think there's great evidence it does much. And there's also some suggestion that this fatigue may be centrally mediated, and there may be changes related to corticotropin releasing hormone and serotonergic neurotransmitters in the brain that have to do with fatigue, much like maybe someone who's running around with not enough steroid in their body, or the same things with that might be mediating depression in people with PSC that may be mediating this fatigue. Next slide. Unfortunately, I don't think there's any great medical treatments for fatigue. I think there's some general management for fatigue that I think are important to consider. I think one is to exercise, and I think just walking 30 minutes a day is a good start. I think it's important to get adequate sleep, because if you're not sleeping well, that's certainly going to contribute to fatigue. I think it's in time, you want to improve your mood, sleep, maybe spend time with friends and family. Perhaps you don't want to spend time with friends and family to improve your mood. Stress management, I think, is important, meditation, yoga. And I think it's important to eat well and to avoid alcohol. Next slide. Now, complications of cirrhosis I'm going to talk about here, and I'm going to talk about hepatic encephalopathy and ascites. I will say that I'm known by the fellows here to try to simplify the description of what the complications of cirrhosis are by describing what a normal liver is, like a sponge, and a cirrhotic liver like a brick. And the blood coming into your liver is like a garden hose. And if you think about a garden hose being turned on into a normal liver, which is a sponge, there's not going to be any resistance to that blood flow of the water going through the sponge. But if you were to cover the end of a garden hose with a brick, you would increase the pressure in the hose. And if you were to have a soaker hose, one of those hoses you use in the garden, it would start leaking water out the side of that hose. That's like what happens when ascites develops in the body. And when you can't drive water through a brick, it's like not being able to drive blood through the liver, and blood is going to go around the liver, and it's going to carry toxins around the liver, and that's what happens with hepatic encephalopathy. Whether that was helpful to you, I don't know, but that's how I try to explain things. Next slide. So hepatic encephalopathy is a neuropsychiatric complications of cirrhosis, and it results from this shunting of blood from the portal system, the blood coming into the liver, around the liver, back to the systemic circulation. Having a liver that doesn't work very well is also likely required to develop this, because you also get blood supply through the artery. And if you have a functioning liver, you can probably clear toxins through the artery. And what is happening in this situation is you're failing to metabolize neurotoxic substances. And one of those toxins is ammonia. Next slide. So this slide on the bottom shows the colon, where ammonia is produced both by bacteria and the breakdown of protein. It goes to the liver, and normally it would be immediately cleared by the liver. But if you can imagine your liver is like a brick, you're not going to get blood through the liver, so it's going to go around the liver. And when blood goes around the liver, it's not going to be cleared. And then these toxins are going to go to your brain, make you goofy and confused. Now, what I've shown here in the liver here is also what's called a TIPS. A TIPS is a transjugular intrahepatic portosystemic shunt. It's a little tube through the liver. It was placed there by a radiologist, and it was used to treat either ascites or bleeding veins in the esophagus. And it's like drilling a hole through that brick I was talking about. Now, when you put the garden hose up against the brick with a hole in it, the water can flow through there. And that's also carrying the toxins through the liver, and they're not being cleared, going to the brain and making you confused. Next slide. So when you think about hepatic encephalopathy, you need to think about the things that cause it to happen. One would be excess protein. When I say excess protein, I'm talking about a 32-ounce steak. I'm not talking about just having more protein, because most people with liver disease need more protein. But if you were to eat a 32-ounce steak, you probably, and had severe liver disease, it might make your goofy problems thinking. I talked about the TIPS procedure. An infection will make this worse. Bleeding protein from blood will break down into ammonia. Taking sedatives, kidney failure, diuretics, too many of those will also cause confusion. So it's important whenever you have this condition to think, what am I doing that may be making this worse? Next slide. So whenever we see someone who's having a hepatic encephalopathy, especially an acute case of it, you want to look for some of those problems I talked about. Now, the treatment of hepatic encephalopathy is to get things moving through the bowels faster. And that's where lactulose comes in. Lactulose is a non-absorbable sugar that doesn't get absorbed, but it pulls water into your colon. And when you pull water into your colon, you get diarrhea. When you get diarrhea, you're moving things through the colon faster, so there's less time for ammonia to be absorbed. The lactulose also will acidify the stool, binding to the ammonium and making it ammonium, which can't be absorbed. Now, rifaximin is a non-absorbable antibiotic that is also used to treat hepatic encephalopathy. Bacteria can make ammonia, so this non-absorbable antibiotic will kill the bacteria in the colon, reducing the ammonia production absorbed from the colon. It's important to also consider zinc replacement if you're deficient. This can be common in people with end-stage liver disease like cirrhosis. And then finally, there is a substance called L-ornithine L-aspartate, or LOLA, which is a substance necessary in the metabolism of ammonia. And I have sometimes prescribed this to refractory cases of patients with pretty impressive benefits. It can be purchased off Amazon. Next slide. Now, ascites is fluid in the abdominal cavity, and cirrhosis is the most common cause of ascites, with 80% of people with ascites having cirrhosis. It is the consequence of this problem with blood flow through the liver, where you hold on to salt. And when you hold on to salt is because your kidneys are tricked into thinking you're dehydrated and dying of thirst in the desert created by the problem you have with blood getting through your liver. And when you hold on to salt, you hold on to water. When you hold on to water, you fill up with fluid. So the management of ascites is largely to restrict salt and get salt out of your body with diuretics. And it's important to know that the presence of ascites itself, irrespective of any other scoring system or any other complication of liver disease, is a reason to be considered for liver transplantation. Next slide. Now, the treatment of ascites really involves whether or not you have problems related to it or not and how bad it is. Next slide. Yeah. So if you don't have ascites, you don't really need to worry too much about it. But if you go to a barbecue and you have a bunch of barbecue and then you take in a bunch of sodium and then you fill up with fluid, that could precipitate it. And I did have a patient once have that happen to her, and that was her presenting symptom of ascites. Next. Now, if you have just small, uncomplicated ascites, if you have a lot of discomfort from it, it can be removed once. But largely, the management's going to be salt restriction, less than 2,000 milligrams a day, and diuretics. Diuretics are often called water pills or water-releasing pills, but they're really salt-releasing pills. They get rid of salt out of your body, and if you have a net loss of salt, you'll lose fluid and ascites. Next slide. Refractory ascites is when you take all the diuretics in the world and they don't do anything, or you're suffering complications of those diuretics, like kidney failure or metabolic derangements. In which case, then you're left with doing large volume paracentesis, where you stick a needle in the abdomen to drain it as needed with albumin. You can do that TIPS procedure I talked about, where you kind of the equivalent of drilling a hole through the brick. And then there's also liver transplantation. Next slide.
Dr. Burton, in the interest of time, if you don't mind wrapping up after this slide.
This will be, I will be right down after the sleep disorders and cirrhosis. This is very common in people with liver disease. About 2/3 of patients with cirrhosis will report sleep-wake disturbances. Most patients with cirrhosis describe themselves as poor sleepers. And it may be a complication of undiagnosed hepatic encephalopathy, and it can have a big impact on someone's quality of life. Next slide. So I think it's just important to realize that people with cirrhosis do have sleep disorders. Low albumin may play a role in this because they can't clear some of the toxins that may be contributing to it. I think people with cirrhosis need to have good sleep hygiene. Next slide. I think it's important to, avoid eating late at night, unwind early, do not have a lot of screen time before bed, have a little glass of warm milk, keep a cool room. And bed is only for sleep. If you go to bed, you can't get to sleep in 20 minutes, get out of bed for Christ's sake and do something else. Avoid naps during the day, no alcohol, no caffeine, and exercise. Next slide. And that's it. I'm done. Thank you.
Thank you to all three of our speakers. They were great talks. And now we'll transition to the question and answer segment. The first question I would like to ask Dr. Forman, you had presented some of the ambiguous data regarding the utility of low-dose ursodiol. When would you recommend that we should or shouldn't prescribe ursodiol for our patients with PSC?
So most patients that have been sent to the university tend to already be on urso. And I would, for itching, it may sometimes help. I usually have a frank discussion with my patients and tell them that they should not be on it or that it's not really helping. Another, I think, good option, though, is if you want to be on urso, to start medium dose urso, which is 15 to 20 mg per kg. And if your alk phos is still elevated in 6 months, then stop it. But again, we don't know the data from this clinical trial looking to see if it even works or not. So I don't really think there's much role for urso, except if someone's itching. But in my experience, it's not really that effective for itching either.
Great, thank you. Next question for Dr. Kriss. You explained the challenges in trying to diagnose bile duct cancer or cholangiocarcinoma, and you outlined the role of fish. Do you mind talking about why fish has lower sensitivity than brushings or biopsy? And also, could you talk about some of the other results that you can see when you get fish done after an ERCP, because that can be quite confusing.
Sure. And I think just to clarify, so there's actually, the sensitivity is about the same. The specificity is really what's lower for fish. And I guess I'll start with fish. So in fish, there's actually multiple different abnormalities that are described. So if you have an ERCP and have brushings, your fish report could report trisomy, which is 3 of a chromosome. It can report tetrasomy, which is 4. And then polysomy is 4 or is more than 4. And it will actually, if you look at this report closely, it will tell you how many of the cells have that abnormality, because it has to be a significant enough number of cells that have the abnormality to qualify as getting labeled with, for instance, polysomy. Now, because it's not a direct measure of cancer, meaning it's not a piece of tissue that is cancer, that's why it has slightly lower specificity. But when you factor in that, it's actually quite impressive that it's that predictive of cancer when you do have polysomy. I guess the other point I would make is it presented those as 3 different tests. And in clinical practice, all 3 of those tests are done at the same time. And so that, at least in our practice here, and I guess I should mention specifically the cholangioscopy. And that, what that enables us to do is those tests I mentioned have lower sensitivity. But if you combine the 3 of them, you're then collectively increasing the sensitivity of those tests together to detect a cholangiocarcinoma at present.
Fantastic. Dr. Burton, a patient here asked about pain in the liver area, which I can say I hear all the time in clinic. Number 1, what is the pain around the liver? And number 2, what can you do about it? And can I take Tylenol? Is that safe?
Well, I have many patients tell me they have liver pain, and I think if you have liver disease and you have pain in your right upper quadrant, who am I to say it's not liver pain? I do believe it exists. I mean, typically pain in the liver is a result of stretch of the liver capsule from something in it, like a tumor or a blood clot. Though you can also get pain from obstruction of the bile ducts. So I do think liver pain is real. It is a bit challenging in terms of how to fix it, because if you don't have a tumor in your liver and your bile ducts aren't, anything obviously obstructed, then it's really challenging to treat that. I'm hard pressed to recommend someone have a liver transplant for pain alone. And there's no guarantee that it'll get better after a liver transplant, and that's certainly a way to create more pain. Tylenol is certainly safe to take. We give 2,000 milligrams of Tylenol to the person at the top of our transplant list. I think with more advanced liver disease, you do want to stay away from ibuprofen, Motrin, and Aleve. Those drugs can cause gastric irritation. I talked about that shunting of blood around the liver. You get more bleeding, and in severe cases can cause kidney failure. But I do think liver pain is real, and I guess how to deal with it can be very challenging if you don't have obvious explanation for it.
Great. Moving back to Dr. Forman, you outlined a number of exciting potential therapies that are all in the pipeline and being researched. Which of those do you think has the most promise and or maybe the closest to being approved for use in patients with PSC?
Yeah, I wish I had exciting news on that front, but we're all still, for the most part, in phase 2 trials. With COVID, unfortunately, most every trial was on hold, and we had a number of studies that we couldn't even start. I'm excited personally about bezafibrate as an option. Berberine also is something that you can get. It's a Chinese herb that has been used in China for years for all sorts of things, but preliminary data from the berberine urso study also seems promising, but nothing really is that much closer to prime time, unfortunately.
Got it. Thank you. Dr. Kriss, I have a question here back to fish. Is that just a one-time test, or can you do serial fish tests, and how do you interpret that?
Yeah, that's a good question. So we usually do them serially, especially if they are abnormal. And so the problem arises when you have polysomy that gives us concern, and then you have a follow-up test where that has resolved. Now, in one sense, that's good. But all of these studies that have looked at the outcomes are based on the initial fish analysis. So there is some uncertainty when you get to that. But I would say in most cases, patients have more than one fish analysis, and it's usually coinciding with an ERCP to evaluate new or worsening stricture.
Great, thank you. Dr. Forman, back to you. We have a question here about, is pregnancy safe in patients that have PSC? Could you comment on that?
I think it really depends. PSC in itself, first of all, is not associated with infertility. And patients that do get pregnant that have PSC might have a higher incidence of cholestasis of pregnancy, a disorder where you itch quite a bit, because PSC, again, already is a disease involving the bile acids. But they absolutely can get pregnant and deliver safely. You don't have to necessarily worry about a C-section, versus vaginal deliver. If, however, a person has PSC that is associated with cirrhosis or is associated with portal hypertension or elevated pressures in your vessels, even if you don't have cirrhosis, which sometimes occur, I would definitely recommend you talk to your doctor, because there is a higher risk of bleeding and higher risk of variceal bleeding, which can harm you and your baby. But outside of portal hypertension and cirrhosis, absolutely.
Great. Dr. Kriss, we have a question here about how do you stage or how would you describe the various stages of PSC? And might I add to that, you went through a great talk of all the different tools that we have to tell us information about your liver and PSC. In general, how would you say what tool is most useful for staging someone's particular PSC?
Yeah, so I think that's a great question. There's two ways that I think about how you stage PSC. So the first that's straightforward is, for any chronic liver disease that leads to scarring or fibrosis, we define those levels as stages. Okay? And so in that sense, a FibroScan that I mentioned can actually tell me, based on the range of values, what stage of fibrosis or scarring that patient has. And that's, again, uniform across all liver diseases and applicable for monitoring changes over years to decades. I think the other thing that we think about is, what are the clinical stages? So what's happening to this patient's disease? So is this someone who has had an abnormal MRCP and hasn't had issues for 5 years other than slightly abnormal labs? Or is this someone who did well for a year, then had cholangitis every 6 months, then cholangitis every 3 months, now cholangitis every month? And in that case, while I don't know that there's a great way to define that, I would consider that patient having progressed through clinical stages, where even in the absence of the scarring stage, I might say that their disease has progressed.
Great, thank you. Dr. Burton, we have a question here about diet. Should patients with PSC avoid fat in your diet to prevent cholangitis episodes, or still eat a normal amount of fat to stimulate some bile secretion?
I would say that no one should have a high-fat diet, if that answers the question.
I have a question about the role for liver transplant. I think you went over some of the indications, although I think many of us are aware that there's different reasons of why we should consider liver transplantation for patients that have PSC compared to other forms of liver disease and cirrhosis. Could you outline when you think it's really appropriate to push for liver transplant, and should that be based on symptoms or labs, or what are your thoughts on that?
That's a really great and complicated question. I think Dr. Kriss had mentioned to everyone what a MELD score is, which primarily applies to people that have cirrhosis that is mainly affecting the liver cells. And so when people have, for example, liver disease due to Hep C, because all the liver cells are scarred, it starts affecting the liver globally. And so you don't make clotting factors, you don't process bilirubin correctly, you start developing kidney diseases. As Dr. Kriss had mentioned, because PSC is a bile duct disease primarily, you can have episodes of infection, but yet your MELD score is still the same. So some people believe that MELD score may disservice PSC patients. However, we published an article a couple of years ago that showed that even though the MELD score might not reflect infection, patients with lower MELDs. That being said, I think anyone with PSC that there is a high suspicion for bile duct cancer, even if there is no bile duct cancer. Once you start having repeated infections and you start losing weight, people that have stents and can't get rid of their stents without getting sick, it's another reason to start thinking about transplant. Dr. Burton, I think, mentioned that refractory itching would be an indication for transplant as well. I think every person is individual and you have to really weigh the risks versus benefits because there are some complications that can occur from transplant as well. As I mentioned, most patients with PSC, we do talk about live donation because they tend not to be competitive for an organ because of that MELD score. So I think live donation is a really great option for patients that have PSC.
Great, thank you. Dr. Kriss, I have, I guess, two questions for you. One is, what is the role for ERCP? When should we do an ERCP? And specifically in patients that have no symptoms, is there a role for an ERCP? And also, how is that compared to other modalities like ultrasound, CAT scan, or MRIs?
Sure. So I think in general, the way our clinical practice is shifting, we're actually doing ERCP less and less. And that's because MRCPs specifically have gotten so much better technically as far as the resolution and the pictures they give us. I'll mention just briefly, ultrasound and CAT scan can be helpful in some instances and complementary, but I don't consider those in the same kind of level of diagnostics as an MRCP would be specifically for PSC. Now, as far as your question, when should we be doing ERCPs, and are there times where, obviously if someone has cholangitis, they need an ERCP, but what would be scenarios where you're not having symptoms? So I think it's important to note, if you just have progression of PSC without what we call a dominant stricture, that in and of itself is not a reason to have an ERCP. And I think in the absence of symptoms, the main reason is to evaluate a new stricture to make sure that new stricture is not concerning for a cholangiocarcinoma.
Great, thank you. Dr. Burton, could you comment on itching? Is itching caused by liver cholestasis? And is it possible if the bilirubin is normal, can people still have a lot of itching?
Oh yeah, absolutely. I think I've seen some incredible itching in patients who have normal bilirubins but have an alkaline phosphatase of 1,000. So I mean, keep in mind if you're obstructing a tiny intrahepatic bile ducts, you're going to have poor bile flow, but you might not turn jaundice. So you could certainly have severe itching without developing jaundice. I think the people, and on the other hand, I've certainly seen a patient with severe jaundice who doesn't have itching. So I don't think the correlation with jaundice is required to have itching for sure.
Great, thank you. Dr. Forman, back to you. This is a question I think you covered, but I think it's very important and we hear it all the time, especially as there's misinformation about overall prognosis online that patients and their caregivers read. So the question is, at what point do most patients why there's such a wide range of answers and oftentimes misleading?
Again, it really depends, and there's lots of different reasons for PSC in particular why someone would need a transplant. Again, this is not a disease that often leads to cirrhosis, although that is a complication, but in the minority. So people on initial diagnosis actually might have a bile duct cancer, and that might be their indication right then and there, even though you just were diagnosed. People can be completely asymptomatic, not have any symptoms whatsoever, even though they have a lot of scar tissue and never need a liver transplant. Someone might have an episode of infection and get really worried, but they might not have another infection again for 5, 10 years. So it is very difficult to predict. And again, the things that I look at primarily are infection rate. If they're starting to get more and more infections that cannot be controlled. I look at weight loss, because patients that start doing poorly with PSC will start having unintentional weight loss. I take that very seriously. And whether they have a live donor, quite frankly. If I think their quality of life can be improved and they have a live donor and we talk about the risks versus benefits, then I think transplant's an option. I think it's a discussion that you really have to have with your hepatologist, because it is complicated. I'm even struggling just to answer your question in general terms. Often patients with PSC do really well for a while and then hit like a wall. And all of a sudden, you know, they just have this downhill trajectory that can't be stopped, in which transplant's the only option. But that doesn't occur in everyone. I think a lot of the literature and a lot of the stuff on Google suggests that, you know, it's a death trap and you might as well start lining up your donors day one. And I do not think that that's the case. And hopefully with some of these new medicines, if they're approved in the next 5 years, it will change how we think about PSC.
Absolutely. I think we have time for one more question, and Dr. Kriss, I'll leave you with the last question. There are several questions here about what tests do patients routinely need with PSC, and also should this be impacted by the coronavirus pandemic in terms of does testing still need to be done, and how can we do that and see a hepatologist?
Regarding how frequent we check tests, I think in most of our practice, and myself included, I tend to check a liver panel with if they have advanced disease and INR, as well as blood counts every 3 to 6 months. And then the CA19-9, I tend to monitor annually with the MRCP. I think from a liver specific perspective, those are the things that are most important. The only other thing I would mention is Dr. Forman had mentioned the increased risk of colon cancer. And so I would consider in those with inflammatory bowel disease that dysplasia screening annually would be another priority. And I would be different now than they were a few months ago. But a few months ago, if I had a healthy PSCer who was due for their 3-month labs, I was sending them a note saying, why don't you tell me if you feel badly? Otherwise, let's check labs in 2 to 3 months, because it's not going to change how I take care of you now.
Fantastic. Well, again, I'd like to thank the speakers. I think you all did a fantastic job of covering a lot of topics and a lot of detail. And I hope that the patients and caregivers that are watching and participating in this have found it helpful. I certainly have. Ricky, back to you.
Great. Thank you so much, Dr. Forman, Kriss, and Burton, for thoroughly covering the basics of our disease and making us more knowledgeable about what to expect in our PSC journey. It was really great. We will be posting the recording of the session on the conference page of our website for those who'd like to listen in again, because there was so much information, it's hard to absorb it all. I'd like to thank everybody again for participating tonight. And as a few final reminders, please take the time to fill out our surveys for October PFDD meeting, for our registry, and for patients who've been diagnosed with COVID-19. It's an easy way to help our entire community. If you haven't yet joined our patient registry, now is the time. Visit the COVID-19 page on our website for updated information on COVID and PSC. Sign up for a mailing list so you can remain updated on all of our programs. Watch for our continuing conference webinars. Join our Zoom room patient caregiver gatherings. And feel free to send us your comments about this webinar and suggestions for future webinars at contact@pscpartners.org. Thank you again to our webinar series sponsors, our conference co-hosts, University of Colorado Health and Children's Hospital Colorado, and our other corporate sponsors, Gilead, Mirum, Intercept, Alvareo, and Shire, for their support of our virtual conference series. Please stay in touch with us and stay healthy. Thank you. Bye-bye.